Good morning, Peter Goertz. I'm a psychiatrist. Let's talk about delirium. If you do consultations for patients on hospital wards as a psychiatrist, you often get called for delirious patients. And specifically, generally, if you get called for a delirious patient, it's for that patient being agitated. And there are as often possibilities that you can be blindsided. I was called last week, for instance, for a quote, depressed patient. And it turned out the poor gentleman, he was an older gentleman, when I started talking with him, he didn't know what city he was in. And I asked him twice and he said the same other city, which was, way across the country. So you want to definitely check people's cognition, especially if there's any suspicion for delirium or cognitive issues. But also in general, like I said, you can be blindsided. And yesterday also I saw a patient, a younger female patient in the emergency room who had unintentionally overdosed on medications because of a mistake. And she seemed pretty coherent. She answered questions appropriately, but then when I asked her what month it was, she was quite a ways off. So again, there's often the possibility that you could be blindsided. What is delirium? Delirium is fluctuation of consciousness and cognition, and generally rapid fluctuation, as opposed to dementia, which is cognitive impairment that's generally steady with preserved consciousness. And of course, you can have a combination. You can have someone who's demented who on top of that then becomes delirious, let's say, from a medical issue. So generally or often medical issues are at the root of delirium. For instance, especially in older patients, a urinary tract infection. Another issue, not infrequently, is alcohol or drug withdrawal, like, for instance, Xanax withdrawal, benzodiazepine withdrawal in general. And you want to address the medical issues if they're there. You want to address the substance withdrawal, of course, if that's there. And that way you address the root causes of the delirium itself. And you want to not focus solely on medication to treat agitation and delirium also. And to treat delirium in general, you want to focus on other things aside from medication. So you want to have consistency for the patient. If possible, you want family members to be around frequently or friends. And you want to have the patient have as few changes in their environment as possible. Maybe have pictures from home, if possible, brought to the hospital. Another aspect in general that you deal with as a psychiatrist is, does the patient have the capacity to participate in medical care? Does the patient have capacity to refuse necessary medical treatment? In general, at least, a delirious patient does not have capacity to refuse necessary medical treatment. And it's always good if someone has another person who's appointed as a power of attorney, who has power of attorney for the patient and can make those medical decisions if necessary. So we get called as psychiatrists for delirious patients often because they're agitated. They're causing a problem with treatment. They're difficult for the staff to cope with. And as far as medication treatment, often we give antipsychotics like Haldol or Zyprexa for delirious patients who are agitated. But of course, you want to be careful. You want to check the EKG, specifically the QTC, because if they already have a prolonged QTC, you're at risk of further prolonging the QTC with Haldol or Zyprexa, for instance, and that can be a major issue. An advantage of Haldol is you can give it orally, intramuscularly, or even intravenously. The Zyprexa you can give orally or intramuscularly. Another option that we often use nowadays for treating agitation and delirium is valproic acid. So that can be given orally or IV. The oral form might be Depakote. The IV form is valproic acid. And again, you want to be careful because if someone has low platelets or elevated LFTs, so liver issues or a low platelet count, valproic acid might not be the best thing to give because Depakote or valproic acid can cause thrombocytopenia, so low platelets, and also can cause liver dysfunction. So that's a caveat with Depakote. So sometimes you get patients who have a prolonged QTC and have low platelets and maybe elevated LFTs, and then you can really be in a bind as to what to give them, what medication to give them for agitation in their delirium. So it can be difficult. And last week, I had a patient who was on the antibiotic linezolid, the patient was delirious. The patient was on Depakote, but they were also on the antibiotic linezolid, which can also cause low platelets. And they had low platelets. So were the low platelets from Depakote? Were they from linezolid or a combination? So things, again, as often can be tricky. As a general rule, you want to avoid benzodiazepines in someone with delirium unless the delirium is from benzodiazepine withdrawal or from alcohol withdrawal. You also want to avoid hydroxyzine or other anticholinergic medications. Thank you.